That's 100.
Oh, okay,
You
yeah,
can
when was that
do
due?
it. It says on there.
Okay.
I think it's due like week 10.
Okay, and when are you gonna tell us like
Yes,
the?
week 10. You pick whatever, anything vascular
How
related
it,
you want to
but
talk
you said
about.
you were gonna tell us what font and.
Yeah, do like, I think I said 12 font, 2 pages, 12 font, and then add pictures. I don't need any sort of, resources or whatever, I mean,
Yeah.
just give me some pages and give me 2 pages of whatever you're talking about. Yeah, thank you. And then, as long as it's due about that date, it's 100, so.
So 300 words is
I guess.
whichever one goes first.
No, do 2 pages. 2 pages, yeah. I'm not, yeah.
Well, I had down 300 words, so one
Let's just
was.
do 2 pages. Oh, really? Good, okay. That works out. Let me see something. Anything vascular. So far, all y'all really know about is chlorotics, but if you want to research something, you can. You can research DVTs, Berger's disease. Y'all know, if y'all seen the commercials of the people that smoke, they lose their legs and stuff like that. You can, anything vascular you want to research. Graft, stent, endorectomy, but different vascular operations you can have done, different vascular ultrasounds you can have done, anything you want to talk about, I don't care. Yeah, I have a grade here for you, so I guess I gave it back. I'm going to be here late today, so if anyone wants to stay over, I'm going to be here till at least 6, at least. So whatever y'all need, written, scanning, whatever, okay, I'll be here. And it doesn't have to be just vascular, I mean, I know how to do it all, so. I'm not trying to sound like that's a big head, but I know how to do it, okay? So I can help you in abdomen, do my repro, whatever.
How about Thursday? Are you gonna be
I'm not gonna be working late Thursday, so I'm working late tonight.
Thursday morning?
I get here about 9, and then I have class from 12:30 to 5. So, the only problem with Thursday morning, as the lab goes, is I don't remember if abdomen, if the seniors are in there first thing in the morning. But I know there's a break from 10 to 12 for their physics. You may want to check them in the morning class before you get here that early, because they do take up every machine. So, okay. So we're going to go over vertebrals today. Did everybody get a chance to scan them in class? Some didn't? Okay. If you did not get a chance to, what you'd want to do, and I'll show you today if you stay, is lengthen your CCA out and long, and just angle back towards the bed, and you're going to see the spine shadow down. If you look on page 89 at the bottom, it looks just like this picture. And I've got one again full of it. Bottom of page 89, you can see the spine process shadowing down, and the vertebral arteries sit on each side of them. So some people have a really long vertebral artery. Who wasn't in here that was scanning somebody and their vertebral artery like took up the whole page, the whole screen? Like it was you. Who were you scanning the other day? Me. Somebody, like their vertebral took up the whole screen, which was cool. But anyhow, sometimes you can just get one vertebral, sometimes you can get 2, sometimes you can get 3. It's all about how close people's spine, their columns sit, together. So just be aware of that. But some reasons on page 89 to why you would want to do a vertebral exam. Okay? Flow direction. We know that vertebrals are supposed to be antegrade, and they're supposed to be flow resistant. Okay? What do the vertebrals branch off of? the subclavian, and then they join the foreign basilar. Yeah, okay. What is something that we've learned about to why the vertebral may become retrograde? If there is a CCA occlusion, because E is feeding I, what's going to feed E? Vertebral basilar. So that's one reason. So it's very important that we look at the direction. Okay, vertigo, any of the vertebral basilar symptoms, vertigo, syncope, drop attacks, any of those things could mean that the vertebral artery has a stenosis in it, or it could be completely occluded. So it's important for us to know what symptoms they're having. Another thing that you'll start scanning is the subclavian, okay? We know the right subclavian comes off the innominate, left subclavian comes directly off the arch. We know the vertebral comes off the subclavian, and then they join for basilar, okay? But subclavian also travels down and forms the axillary artery. So we'll learn the anatomy of the arm soon. So you do need to check the subclavian for different reasons. If the vertebral is retrograde, it's probably, if it's not because of an occlusion in the cerebrovascular system, it's because the subclavian is probably occluded. So it's backing up, since the vertebral comes off the subclavian, it's backing up to feed the subclavian. So that could be another reason why vertebral is retrograde. It's important to know how to scan the subclavian. A very common finding is you go to the doctor and they do blood pressures on you. Most of the time our doctors only do one arm. But if for some reason they do both arms and the pressures are more than 20 from one side to the other, that normally means that they have a subclavian stenosis on the lesser side. So if I come in the doctor, my right side's 100, my left side's 140, that's more than 20. So my right side has the subclavian stenosis, okay? We want the lower pressure, and that will be a test question. So a difference of more than 20 from one side to the next in your brachial blood pressures usually indicates subclavian stenosis on the side with the lower pressure. And that's what it says, reduced arm blood pressures, okay? So difference of more than 20, the disease is to the side of the lower. A bruit, does anyone know what a bruit is? It's an abnormal love dove sound. The normal heart has that love dove opening and closing. A bruit is an abnormal beat that you can hear. You have to have a stethoscope to be able to hear it. But if they have a bruit, chances are you're going to be able to pick it up on the ultrasound. It's just your waveform is going to have either an extra beat or it's going to go way down below the baseline. It's just going to look abnormal to you, okay? So a bruit is an abnormal love dove sound. And then it says another reason due to subclavian is an abnormal vertebral waveform, which is what I just talked about, okay? So if the vertebral is high resistant or if it's retrograde, we need to be looking at the subclavian. It can be antegrade and high resistance. We still need to look at it, okay? So either retrograde or high resistance, you need to look at the subclavian. What was the bruit again? It's an abnormal love dove sound, an extra beat in the heart. And most of the time, if a patient has a bruit, they have a stenosis. But it doesn't always mean that, okay? So just because a doctor, and there, a lot of doctors are going to order carotid stents for bruits because they think there will be a blockage there. But it doesn't always have to be there. So bruit can mean blockage, but it doesn't always mean. All right, going under vertebral imaging, the second sentence, the arteries are assessed between the transverse processes of the vertebrae. Because it is often difficult to image this origin of the vertebral vessels, especially on the left side, careful attention to the morphology of the waveform is necessary to detect disease. Again, it's important to know what type of waveform they have. We're going to go over all the different vertebral waveforms in a minute. But how do you find it? Find the 60A and long. Scan posterior or laterally until you see the shadowed vertebrae. Color may also be helpful. And they're going to lie between the transverse processes of the vertebrae. But caution is recommended to determine flow direction. So just on this page alone, they've mentioned 3 times where the vertebral direction is very important, okay? If you want to turn on over to page 90, it tells you to place your sample volume between the vertebrae. Be careful that you're not on the spine, be in the artery. That's what it says. Be careful that the Doppler reading does not come through the bone, as it will weaken the strength. And the Doppler gain usually needs to be increased due to the depth. Okay, so that's saying if you know you're on the artery but you're not picking up a waveform, turn up your Doppler gain. And I showed some of y'all how to do that, where it gets really bright in the background. That's the only way you can see your waveform. So you can do that. Again, record spectral waveforms and pay close attention to the direction of the flow. The vertebral arteries on many elderly patients is difficult. Why? Because as we get older, we get shorter, right? So our spinal columns get closer together. An attempt should be made to image the proximal vertebral artery on symptomatic patients. So that means right as it comes off of either the innominate or the arch. Proximal is always closest to the heart, okay? So that's where you want to be if a patient is having vertebral basilar symptom, or if they're having the flow is reversed, or if their subclavians are more than 20, anything like that. You want to pay close attention in Doppler right as it comes off. Alright, subclavian steal. Now I said they have subclavian stenosis. The technical term for that is subclavian steal. Okay? So if a patient comes in, more than 20 from one blood pressure to the next, we're thinking subclavian steal. It's the most common vertebral pathology, and it occurs more commonly on the left side, but of course it can always occur on the right. One reason is the left subclavian is bigger than the right side. Okay? Now, if you find, it says proximal subclavian stenosis or occlusion can cause the vertebral to reverse. Okay? Just like I said, if the vertebral is reversed, but it has nothing to do with the carotid system, it's probably the subclavian is stenosed or occluded, making it steal from the vertebral. Why? That's what's called subclavian steal. It's stealing from the vertebral to get flow to it. So it says the vertebral becomes retrograde, either completely or partially. That's a key word there, completely or partially. If you have a stenosis, do you think that the vertebral is going to come completely retrograde or partially with a stenosis? Partially. When it's occluded, that's when it comes completely retrograde. Okay? So if you're getting a partially retrograde vertebral flow, means it's antegrade sometimes, retrograde another. That means there's a stenosis in the subclavian. If it's completely retrograde, that's an occlusion. Okay? So it does this to supply blood flow to the arm. I mentioned subclavian goes into what? Axillary. And then axillary goes into and provides the arm. So you've got, just like you got to get flow to the ICA to the brain, you've got to get flow to the arm, and the arm's going to fall off. So subclavian is occluded or stenosed, meaning it's limiting how much blood flow gets to the axillary to supply the arm. So it's going to steal from the vertebral to provide flow to the arm. Okay? So it's stealing from whatever it needs to. Now, if the vertebral is becoming retrograde, what do you think is happening to the basilar artery? Basilar artery flow is decreased. From the back of the head, the posterior hemisphere, flow becomes decreased, which results in vertebral basilar symptoms. Okay? So it doesn't just have to be a carotid issue to cause vertebral basilar symptoms. This will also cause symptoms. The vertebral is, let's say it's the right side. The right vertebral is being reversed to feed the right subclavian, so the right subclavian feeds the right arm. Right? If the right vertebral is reversed, and that means the right basilar is not getting the adequate amount of blood flow, so the right posterior hemisphere is not getting the adequate amount of blood flow, which can cause symptoms. So again, very important to know what symptoms the patient's having and what type of flow is going on in the vertebral. Usually subclavian steal does not cause neurological symptoms. Usually. However, it can, especially if you've got, bilateral subclavian disease. Then that means both basilars are reversing. Okay? Both vertebrals are reversing, stealing from both basilars. It doesn't always have to cause symptoms. This is where it says, however, in the presence of severe carotid disease, now we talked about it, if the carotids are occluded, how does ECA feed the eye? How does the ECA get fed? Vertebral basilars. Okay? So in the presence of severe carotid disease, flow in the basilar will become reversed, right? So feed E, which again will cause neurological symptoms. This is known as subclavian steal syndrome. So in carotid disease, if the vasculars are backing up to survive or to provide the E, this is called subclavian steal syndrome. Although subclavian steal is frequently detected with ultrasound, the steal syndrome is less common. Okay? So saying subclavian steal is easily seen with ultrasound. It's where the subclavian is stealing from the vertebral. Alright? Why is the steal syndrome, the one that involves the basilar, less common? Because you can't see it. Because you can't see basilar. Very good. Right? Can't see basilar. So we, as ultrasound techs, cannot diagnose retrograde flow in the basilar, which means we cannot diagnose subclavian steal syndrome. They'd have to have an MRI or CT done. Very good. Now, here is a very interesting fact on the next one. In the presence of an innominate or a subclavian artery obstruction on the right side, why does it specify the right side? Because you don't have an innominate on the left side, right? You have an innominate on the right, dividing the right subclavian. So on the right side, the right vertebral flow can reverse direction to perfuse the arm, so the subclavian is stealing from the vertebral to supply the arm. If retrograde flow is detected in the right vertebral artery, the subclavian and the innominate should also be carefully evaluated. So here are the steps that you need to know. You're scanning, you find retrograde flow in the vertebral. Automatically go and check out the subclavian, okay? Because chances are the subclavian has got some stenosis, so it's pulling flow from the vertebral. Alright, so that's your first step. Find retrograde flow in the vertebral, check your subclavian. What happens if you get to the subclavian and it's also retrograde? Anytime something's retrograde, that means something is stealing from it. Okay? So if your vertebral's retrograde, now you look at your subclavian and it's retrograde, what do you think the subclavian is feeding? What does the right subclavian come off of? The innominate. Chances are, if the vertebral's retrograde, the subclavian is retrograde on the right side, it's probably because of an innominate obstruction. Right? Probably is the key word.
So if the subclavian is retrograde, it means feeding the...
More than likely feeding the innominate.
Okay.
Not always, though. We're going to talk about the other case that can happen. Right, so you Doppler vertebral retrograde. You have You have Doppler subclavian is retrograde. Now you're thinking innominate obstruction. This is how you check yourself. Jump over and Doppler the CCA. Okay. If your CCA flow is low amplitude and rounded, then it's a innominate obstruction. That's how you can cheat and be sure you're correct. So vertebral's retrograde, subclavian's retrograde, I'm thinking innominate obstruction, I'm going to go directly to my CCA. If the flow is low amplitude, so it has lower velocities, and it's rounded, it no longer has those sharp peaks, it is a innominate obstruction, for sure. If you go to the CCA, it has normal flow, and the innominate is okay, there's no obstruction in the innominate. So think about that. So your vertebral's retrograde, your subclavian's retrograde, your CCA flow is normal, so it can't be a innominate obstruction. Well, what the heck is subclavian stealing to provide? No, because the innominate's okay, because your CCA flow is normal. CCA flow is normal, so there's nothing going on with the innominate. Huh? Yep. It's the proximal subclavian. Okay? So that means the mid or the distal subclavian is being reversed to supply the proximal subclavian. So you as a tech, it's very, hello. Dog, get in here. You did Pat. Yes, she's there.
Yay.
Good job. Hang around because I'm almost done. Okay. Thank God. Third time take that.
Yeah, I was going to say.
Jesus Christ. Okay. I needed that number. All right. So again, your vertebral's retrograde, your subclavian's retrograde. You as a tech need to know, is this innominate or proximal subclavian obstruction. How are you going to do that? Check your CCA flow. If your CCA is low amplitude and rounded, it's a nominate obstruction. Okay? If your CCA flow is normal, it's proximal subclavian stenosis. All right? Remember, anytime something's retrograde, it's because something else is still in from it. So the proximal subclavian is got a stenosis in it, so the mid or distal subclavian is still in from that to supply that proximal. Okay? We do have the steps.
Is that almost like a detective kind of thing?
Yeah, this is what we are. We are detectives. Okay, and we have to, because if it's a nominate, they're going to have different medical treatment depending on if it's a nominate or if it's proximal subclavian. Okay, I don't know the treatments, but the doctors do different treatments for that. And what about the left side? We don't have a nominate on the left side, right? So if your left vertebral is retrograde and your left subclavian is retrograde, all right, what are you going to do now? You do the same thing. Jump over to your CCA flow. If there is an obstruction in the CCA, then the subclavian is providing the CCA. If your CCA flow has an obstruction in it, then it's proximal subclavian again. So the difference from right to left is right CCA with an obstruction will become low amplitude and rounded. Left CCA flow, if it has an obstruction, you're just not going to see any blood flow in that area, okay? Because it's not going to go from the right side, it's not going to go obstruction from, there's not normally going to be a CCA obstruction, is what I'm trying to tell you on the right side. But the left side has a higher chance of the CCA being obstructed, which is why the subclavian is retrograde to feed the CCA.
So in the left, it's the left vertebral, you said, is retrograde, and you check the left subclavian, that's retrograde,
And take the
and
CCA.
there's no blood for that CCA
Obstruction.
on the left side.
Yeah, exactly, because you don't have that anomaly, you don't have that middleman. Yep, and that's why the CCA on the left side has a higher chance of becoming occluded, because you don't have that anomaly in between subclavian and CCA. Okay. So. Yes. Okay. The bottom of 90, that's what it says. Retrograde flow in the right vertebral and proximal subclavian usually indicates a nominate obstruction. Okay? And then I told you the scenario. Check your CCA flow. Low amplitude and rounded, yes, a nominate obstruction. CCA flow is normal, and it's proximal subclavian stenosis. I'm going 91, the last three bullets. Right CCA waveforms are usually abnormal in the presence of right vertebral still. Why are they usually abnormal? Because if the right vertebral is retrograde, normally the subclavian is retrograde because of an nominate obstruction, which affects the CCA. All right? Vertebral arteries are often of different size, and so their flow velocities are not, they're going to be asymmetrical. All right, we said the left side is normally the bigger one, right? So it's going to have higher velocities. Right side, smaller, lower velocity. Okay? Going on over, and this is what we need to definitely go over real quick. 92 and 93. You will be tested on this, maybe in a quiz form next week, I think. But we need to go over the different types of vertebral waveforms. And also, at the top of 92, you see the first picture, right CCA with a nominate stenosis. See how it's low amplitude and rounded, okay? Then the other one is CCA with a nominate occlusion. All right, if the nominate is completely occluded, it's stealing from the CCA, which makes the CCA become retrograde. That's what that's about, okay? So there is a difference on a stenosis and an occlusion to what type of CCA flow you're going to have when you're dealing with the anominate. So number one, this is normal vertebral artery waveform. Low amplitude, low resistance and antigrowth, okay? That's your normal flow. That's what you want to see. Number two is called resistive spectra, okay? And you can read, it says it's often seen with distal obstruction in the vertebral basalars, so it causes a high resistive waveform in the vertebrals. 3, tardus parvus, low amplitude and rounded. and it is consistent with proximal vertebral artery obstruction. So they found this in the vertebral. They need to look more proximal on that patient. Here's something that you need to know, because this is going to help you throughout your entire career when Doppling an artery. Anytime your artery is low amplitude and rounded, the disease is proximal. Anytime, any artery, don't matter. Just like the CCA, if it's low amplitude and rounded, where's the obstruction? The innominate. The innominate is proximal to the CCA, right? So anytime you find low amplitude and rounded flow in an artery, your disease is always proximal to that. So tardive parvis, this pattern is consistent with proximal vertebral artery. So they found this maybe in the mid-artery, they know the mid is more proximal, and that's where the disease is. Anytime an artery is low, rounded and low amplitude, look proximal. All right, the next is early systolic declaration. This abnormal waveform is consistent with subclavian stenosis, and it's a more sensitive indicator of stenosis than arm pressure differentials, right? Because if you remember, subclavian stenosis can also be diagnosed just by doing blood pressures. But this is saying that the waveform is more indicative than the blood pressures are. So that's early systolic. Number 5 is progressive early systolic. It's also known as the bunny rabbit, and I use that on probably every test. Which one's known as the bunny rabbit? So remember that word. This is seen. It doesn't really tell what it's seen, does it? But it says late systolic flow reverses for a brief period. Diastolic flow is antegrade, and brachial systolic pressures are still going to be symmetrical. So just doing blood pressures, you're going to come out with a normal finding. You would have to Doppler the vertebral to know there's something going on with the subclavian. If you look back on normal, you can see how the flow never goes below the baseline because it's low resistance, right? But on number 5, it mentions how it goes below the baseline for a minute. That means the stenosis is getting higher, and what happens in a stenosis? Resistance and velocity increase, right? So the resistance is getting higher, making the flow go below the baseline, like a high resistance pattern. Number 6 is to and fro. Flows above the baseline for a minute, and it's below the baseline. You can see that. And this is more, so the subclavian stenosis is getting even higher, and with this, you will have the brachial pressure difference. So blood pressures will become abnormal. 7 is complete retrograde. That means this is subclavian occlusion. Subclavian is completely occluded, so it's still in all the vertebral flow. The rest of them are subclavian stenosis, okay? This is an occlusion. And then number 8 is just post-stenotic. If you have, just like any other thing, if you have a stenosis, what are you going to see after it? Post-stenotic flow. Okay? It's an artery just like any other artery. To be sure you know these, either by either looking at the picture or by knowing the definition, or both. And we're not going to go over subclavian right now. Just that you need to know that subclavian veins are very pulsatile, so you may think they're an artery. Okay, and that's on the last page on 96. It says, be careful not to mistake a very pulsatile subclavian vein for an artery. Because it's so close to the heart, it's picking up those vibrations, so you may think it's an artery when we start doing subclavian. And then the last thing you need to know about is thoracic outlet syndrome. I put it on your little fill-in thing for class. Sometimes the subclavian and axillaries become compressed, right? And it has to do with your position of your arm. So let's say I put my arm out like this, and if my subclavian and axillary become compressed, cutting off blood flow, what's going to happen to my arm? It's going to start tingling and get numb, right? All right. So, but you can put your arm in any position. I can say my arm's like this, and it goes numb. That's thoracic outlet syndrome. So the subclavian or axillary artery are being compressed, and it's either by a muscle or you have what's called a brachial plexus through here. And so whenever you put your arm in certain positions, the muscle compresses the artery or the brachial plexus compresses the artery. The only treatment is don't put your arm in that position, or they can go in and remove a rib and cut that muscle. that's a very, I've known two of them take so far, they graduated and they couldn't even, maybe they worked a month or so, and they had to have this surgery done. Why? Because they didn't scan their ergonomics right. So they went to this program, wasted all that time and money, and now they can't even work, because they had this really intense surgery on their arm.
If you never did that,
I mean, they could, but it's, they're always gonna be weak on this side. You know, y'all know y'all's arms already sore from scanning, so. But it's really simple. They'll just put what's called a little sensor on their finger and put them in all these different positions. And when the waveform flatlines, that's the position that the subclavian neck plate becomes compressed. So they'll just tell you not to put your arm in that position. But that's it. We made it. Well, a few minutes over. I'm proud. And again, if any of that was too quick, I'm here for 6, so we can go back over it. Okay? It's like that 5.